I'm pleased to introduce Dr. Mona McCalley-Whitters, who will be leading a panel on mental health equity in cancer care. Dr. McCalley-Whitters is an accomplished psychologist with over 30 years of experience in psychiatric research, community activism, and nonprofit leadership as the former executive director of NAMI Lynn County. Currently, she is the executive director of Cedar Rapids Psychiatry. Welcome, Mona, and all our panelists.
Thank you, Kelly. And we'll just have a moment or two here for the panelists to get situated. If you need to stretch or kind of move around, please feel free to do so. Yeah. Are you guys all good? 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 Calm down. Well, as you heard, I'm a psychologist, and I'm very excited to be talking about mental health. That's my gig. And we have some experts here from around the state that will also be having a dialogue and conversations on mental health disparities and its impact in cancer care. So today, we will be looking at prioritizing mental well-being along the cancer care continuum. And if you think about mental health in general, you know, we've been through some tough times with COVID, the pandemic. If the statistics show 1 out of 5 persons will be diagnosed with a mental health condition in the next year. If you focus that spotlight on cancer patients, research that I've seen is citing 1 out of 3 cancer patients in the hospital have a mental health condition such as depression or anxiety. So there's a lot going on here with the mental well-being in cancer patients. So today, we're going to explore this intersection between mental health and cancer care. In particular, we're going to highlight the unique challenges that cancer patients from a wide variety of backgrounds experience in dealing with their mental health. So, mental health disparities remain a critical issue and have a significant impact on their quality of life as well as their prognosis. I'm pleased to introduce you to our panelists. Some of them you may know from their work with the consortium or their work around the state. Ann Harris-Carter, she's been with the consortium where she is co-chair of the work group, the Iowa Cancer Consortium's Health Equity Work Group, and she's also involved in the Quality of Life Work Group. She's been on many of my panels and is really working hard to make it okay for mental health. Ryan Crane. So Ryan is the executive director at NAMI, Iowa, and hopefully all of you know NAMI, the National Alliance on Mental Illness. He and I have been partners at NAMI for a while, and they do very good work across the state. NAMI is the largest grassroots nonprofit organization on mental health. So his footprint is large and across Iowa, and he'll be giving us his insights today. Jamie Harble, we're excited that she agreed to join. She's the executive director for the Iowa Healthiest State Initiative, and she's been involved in work with me on Make It Okay. And I have to congratulate Jamie because the Healthiest State Initiative is in all 99 counties of Iowa, which is a big deal in a rural state. So you've done a really good outreach and advocacy, Jamie. We did a lot with Make It Okay, especially during the pandemic when things were much more challenging and getting advocacy and messaging out about mental health. She's also worked in telemedicine, healthcare reimbursement, bioterrorism, disaster management, and public-private partnerships. We're also thrilled to have Gabe Martinez here, and some of you may recognize him from his work at the Community-Based Mental Health Center at Broadlawns. He is going to, as a health professional, bring his perspective in tandem with being a cancer survivor. So he'll be highlighting what's it really like on both sides. Max Mowitz, who you may also recognize, he's been involved quite a bit with the Iowa Cancer Consortium. He is the executive director of One Iowa and One Iowa Action. They were recently awarded a grant to help train cancer care providers in the LGBTQ care. So we appreciate their time and talent. Kind of going over the format quickly, there'll be several topics that we'll be examining with kind of a dialogue and exchange. We'll leave a little bit of time at the end for questions and comments from the audience. So go ahead, feel free to put them on the spot with your questions. And if you need more in-depth information, we can connect you to our speakers. So without further ado, we're going to toss things out. And Gabe, I hope you're ready. He's going to talk a little bit about socioeconomic barriers.
Thank you, Mona, for the warm welcome. Thank you, everybody, for letting us be up here today. And one thing that I would like to share, like Mona mentioned, I am a colorectal cancer survivor. I was diagnosed about 2.5 years ago, went through all my treatment, and I sit here today happily to be able to say that I am cancer-free. So thank you for having me. So from my perspective in regards to socioeconomic barriers, I think in my research before coming here today, one thing that really stood out in asking different doctors about mental health, socioeconomic barriers, those that have low income, underinsured, or not insured face what's known as life happens. And I was able to find out that when life happens, it happens harder to individuals that do not have maybe the financial resources or the insurance to be able to provide the appropriate care for their treatment. For example, I was privileged to be able to have good insurance when I was going through my cancer, and I had good resources to be able to go to my treatment, be able to get my treatment easily, back and forth. So when we're looking at individuals that have lower income, when life happens, a flat tire happens here, the car breaks down, they don't have the bus fare to be able to get to their treatment, those are barriers that individuals are looking at when they're trying to decide what's more important. Do I put food on my table or do I go get my treatment? Do I buy my kids' medication or do I buy my medication? So that's something that in talking to doctors I was able to see is an important barrier. Now you compound that with a mental illness, whether it be depression, anxiety, schizophrenia, bipolar. Now you have multiplied life happening even more, because now you're managing not only being able to take care of yourself, you're also trying to manage your mental health on top of being diagnosed with what most people see as a dangerous word, cancer. Because the first thought when you're told you have cancer is, holy smokes, my life is about to end. And that comes from personal experience, because that was the first thing that came to my mind when I was diagnosed. It's like, not me. You know, why me? Not me. I didn't want it. So when you're looking at trying to help individuals, is being able to know what resources are available in the community, so that way you can give that to your patients, to your people that are trying to get treatment, knowing how to make sure that they can afford their medication. I know I hear GoodRx a lot, but GoodRx can only go so far in regards to making somebody afford the treatment that they might need for their cancer. So those are things that we're trying to look at and should be looking at when we're talking to individuals. Another thing that was important for me is that when I first got diagnosed, mental health wasn't addressed immediately. It wasn't, I can't recall if it was asked. I don't think it was asked of me whether I had any mental illness or any previous mental health diagnoses or anything like that. But one thing that sticks out to me is being able to measure a person's resiliency is important in cancer treatment. So I know when I take a resiliency scale, I rate pretty high in regards to my resiliency. And that's something that might be of interest to providers in the room, is looking at different resiliency scales that you can use to try to measure a person's resiliency, because that's going to determine a lot of their ability to be able to focus on their treatment and be able to focus on their care, not just in regards to who supports them, but how do they deal with challenges on a day-to-day basis.
Any comments? Do you want to mention anything in terms of your background, the Hispanic, Latino?
Yes, I am a Hispanic male, grew up in New York City. And it was interesting for me when I got diagnosed because in trying to figure it out, I had no history of colorectal cancer in my family that anybody was aware of. So a lot of the times when I was speaking to my doctors, it was like, this typically has some genetic connection to it. So when I was the first, I get excited to be able to say I was the first to go to college. I was the first to do a lot of things in my family. This was one of those things where I didn't want to be the first, but I'm glad that I was the first to be able to do that, because that was able to trigger me to help my family, help my brothers. I have 4 brothers that went and got themselves checked. I have one brother who now knows he has diverticulitis, a potential that can lead up to colorectal cancer. So now he's aware, his doctor's aware, so they can keep an eye on him as well to make sure that if he were to get cancer, at least it gets caught at an early stage. Mine was caught at stage 3, so I consider myself lucky because And I heard a lot, there's been a lot of discussion about colorectal cancer here today. I wish I would have taken my Cologuard when my doctor gave it to me. That's one of those things that when they send you that box, you look at it, it's just a box, and then you just put it to the side. And I wish those years prior, I wish I would have taken that test. Because it wasn't serious to me. It wasn't important. I was healthy. I was fine. I was living my life. And that's something that I push now to all of my male friends, even female friends. Get yourself checked. Once you turn 45, if you haven't had any symptoms, get on that table and get that picture taken and get scoped out. So if anything, please, if anybody's at that age or above, get yourself checked out just in case, because you never know. And it was just like mine. It never knew. My family was devastated just like I was, but they were happy to see that struggle, that survival of this cancer.
Thank you. Next up, we'll hear from Anne. If you could address some of the cultural and language barriers and your experiences in cancer care with mental health.
Sure. Thanks, Mona, and thanks for sharing. Okay. I'm Ann Carter, and I have the privilege of serving in a health equity role with Lynn County Public Health, and that is a change that I made in my career just a couple years ago. And when we talk about cultural and language barriers, I reached out to a colleague at Eastern Iowa Health Center, which is our federally qualified health center in Cedar Rapids, and they have a statistic that has always fascinated me, and that is their patients speak more than 40 languages. So besides English, the next 3 are, you might guess that Spanish would be the next one, but it's not. It's Swahili, and then Spanish, and then African French. And I bring that up to say, I was born and raised right here in Iowa. I speak English reasonably well. I certainly don't speak 40-some languages. And the reality is we don't have that expectation for our medical providers either. And when we think about what it means, what a wake-up call it can be, and I have not had that experience myself of hearing a cancer diagnosis. I have had the experience of hearing a bipolar type 2 diagnosis. And so I kind of went through this process today in preparing for today of what are some sort of parallel paths, if you will. And I'm just praying that no one will take offense that I'm taking this liberty of comparing the two, but that's how my brain needed to process this. And the one thing that came to mind is just that difficulty of even sharing the diagnosis with others. Everybody has to go through their own journey. Right. Even earlier this morning, Dr. Rathmel said, there's the part of that national plan is engage every person, because basically everybody has a cancer story. I'm sure all of us, if we have not dealt with a diagnosis on our own, we have a friend or family member. And then layer on top of that a cultural difference that's unfamiliar to the provider, perhaps because the origins are not common in this country, or perhaps that provider is just not familiar. And that impacts treatment. I feel like I'm preaching to the choir a little bit, but what I do want to encourage, and this is where my bipolar journey comes in, is, from a cultural standpoint, it really comes down to the individual and understanding, what is it in your background that you want me to know? What is it? Is there anything in your background that you want me to know that might influence how we pursue treatment here? And learn about that culture. When I'm thinking of a dear friend now who, you develop a relationship with somebody, and with mental illness, it took me 10 years. First of all, it took me 10 years to seek out medical help and then the diagnosis. It took me another 10 years before I would even speak it out loud. And I'm still learning how to tell that story. And what I would encourage all of us to do is, for those in your life, whether it's you or someone you care about who have cancer, help them tell that story. Trust me, nobody needs to know the whole story. Nobody. On some days, I might just say, yeah, I deal with mental illness. On other days, I might say, yes, I've taken medication for bipolar type 2 for over 15 years. And some days, in a close conversation, and I've never said this in front of a whole group, I might say, yeah, I'm in a hypomanic cycle and I haven't had a good night's rest for over a week. Right? So what's the corollary from a cancer standpoint? And culture plays into that, because your support system often is those who are closest to you. If the provider is not familiar with your culture, then that definitely has an impact on the quality of care.
Thank you for sharing, Ann. Very powerful story. We appreciate that and your comments on the corollary to cancer care. We're going to switch to looking at geographical disparities and lifestyle risks. And this is Jamie.
Thanks, Mona, and thanks, Gabe and Ann. So when we look at, I think, mental health, let's start there. We know that 1 in 5 Iowans will be diagnosed with a mental illness. So when you start to look at mental health providers and availability of mental health, and my dear friends from NAMI can probably even speak more fluently about this, we know that there are a lack of resources. And we also know that patients aren't being asked when they're diagnosed with cancer about their mental health. So thinking about, if you're an individual who just found out that you are diagnosed with cancer, has anyone even asked the question, how is your mental health? What does your support system look like? I'm fortunate, I would have a great support system if I ever am diagnosed with cancer, but that's not the case for everyone. You have cultural challenges, you have people that are here, maybe our immigrant families, refugees. And so when we look at throughout the state of Iowa, our resources vary drastically. I grew up in Calhoun County, we had a hospital, critical access hospital. Cancer treatment and mental health treatments do not happen in that county. You have to leave that county. And so if you don't have transportation, if you don't have the time off work, it is a major barrier for those individuals who are receiving a cancer diagnosis, but let alone are dealing with challenges within their own mental health. I mean, I can only imagine how scary it is to hear the words, you have cancer, and the impact that would have on your own mental health. And so I think as we look at just the resources we have available, not only for treating cancer, but also for addressing mental health challenges within that population, whether they had a mental illness diagnosis prior to the cancer diagnosis, or if that mental illness diagnosis comes afterwards, that we need to be addressing that whole person and making sure that they have access to those resources, that we are talking about mental health. We know mental health stigma is rampant. It has gotten much better over the last couple of years, and we have people telling their stories, but we have a long ways to go. And I would say, as I've worked in rural parts of the state, and as I go back to my hometown of 300, mental health is still a very difficult topic for many to talk about. But we need to be talking about it because it's not just an individual who may be dealing with a mental illness, and may be someone who's dealing with other chronic health conditions, such as cancer, who now on top of that may have a mental illness challenge that they have to deal with.
We appreciate those comments. And I think in regards to asking questions about the mental health wellness of the patient, it's not just a one-time ask when they're initially diagnosed. Even 5 years, 10 years down the road, it's still impacting their mental well-being. So I think it would be beneficial to continue the conversation and to start it early on. So thank you, Jamie. Those are really good points.
Mona, can I add something to that?
Oh, go ahead, Gabe.
I think as a community-based mental health provider, I've seen the intersection of individuals that have severe mental illness and are diagnosed with cancer. I think a good resource is to be aware of community mental health services that are available in your community, as it's something that can help that individual. Unfortunately, we know that individuals that have severe mental illness have broken a lot of bridges with their families, with their friends, and they do sit alone on an island with their mental illness a lot of times. So it's important for providers to be aware of those community mental health services in their communities, so that way they can connect those individuals to that service, so that way they're not sitting alone when they're getting these treatments or when they're getting diagnosed and stuff like that. As a matter of fact, just recently sat in on a phone call. As a matter of fact, just yesterday sat in on a phone call of one of my workers having to tell a family member that their brother has cancer. So that's what we do as community mental health providers. We try to serve as a bridge to individuals that have severe mental illness, to try to make those connections or be their connections while they're going through their treatment.
Really important information in regards to using resources that are in your community. There may be challenges in some of the rural communities. I did want to point out that the Quality of Life work group is putting together a worksheet on remote support programs for cancer patients and caregivers. I think the key word here is free and virtual access. It's not an exhaustive list, but we'll be publishing it and sharing it with you all so you can get it out to your constituents and their support team. Max?
Howdy. I'm excited to join you all today because one of the things that I think is interesting about talking about mental health and cancer care in the community I serve, which is the LGBTQ community, is that we're looking at a couple of different things that can impact someone's experience of care. So the macro level issues that have already been addressed on the panel today, I think are really important and still in place because when we look at LGBTQ individuals and healthcare access in our state, We do have an LGBTQ health needs assessment that was done both quantitatively in 2021, and we'll have qualitative findings out soon. And those findings show us that LGBTQ individuals not only experience discrimination and harassment in healthcare environments, but sometimes they're turned away from accessing care at all. And so when we look at how that compounds with being a rural LGBTQ person, where you have even less access to the care that you need, or if you are an LGBTQ person of color and you're also experiencing medicalized racism at the same time, those things are building on each other. And so often when we're talking about mental health and cancer care, it's hard to get people in the door to access the cancer care that they need, or even to get screened. Often LGBTQ folks are underscreened for cancers for a couple of different reasons. The first is that often LGBTQ people are more likely to experience homelessness and poverty, which means that they're more focused on trying to make sure that they have shelter next week as opposed to a cancer screening next week. And so those community health resources are really, really, really important. Organizations like Broadlands that are going to serve people no matter what their income is. But I also think that one of the things that I come across often, and I always have to shout out the Cancer Consortium as well as IHHS, is that often cancer care is very, very gendered. So when I'm working with trans and non-binary individuals, in addition to lesbian and bisexual women, they are often least likely to access cancer screening nationwide because cancer and body parts can be very, very gendered. So if you are a person who is really passionate about decreasing the rates of prostate cancer, you need to call it prostate cancer, not men's cancer, because people of all genders have prostates. And so when we don't have spaces that are affirming for LGBTQ individuals to access cancer screenings, and if you're a trans, non-binary, a gender non-conforming person, where the concept of even getting those screenings causes a really intense experience of dysphoria, which is a mental health concern, we want to be making those spaces less gendered, more inclusive to individuals that might need care that is for body parts that can often be gendered. So like breast cancer, we can talk about it as chest cancer. Prostate cancer should be called prostate cancer. Cervical cancer, also cervical cancer, as opposed to men's cancer, women's cancer. Those are little things that we can do that create safer spaces for folks to access the care that they need. And this is also compounded not only from the fact that a lot of the times we'll experience dysphoria or dis-ease when accessing this support, but also because if somebody is experiencing gender-affirming medical care, like hormone replacement therapy, we want providers that know how to accurately address their risk for cancer as well as they transition and access the care that they need to affirm and live as their gender. So we need healthcare providers and healthcare systems that are willing to be LGBTQ affirming, that are willing to treat LGBTQ people, period, which is a huge issue in Iowa. And then also we need to make sure that we're creating these safe spaces so that LGBTQ folks are not experiencing stigma, violence, and, intense dysphoria when they're just trying to access the cancer screenings they deeply need. And this is something that we see all across our country. So often when we're talking about mental illness, and cancer care, it really has a lot to do as well with someone's sexual orientation and gender identity, which means we need to be asking those questions. We need to have a good medical history for that person, and we need affirming providers that can support those individuals. And you shouted this out earlier, so I want to say it again. We have a fun little table out at the front, and you should come say hi to us because we have free trainings to tell exactly what I'm talking about. We can do that for you for free because of the support that we've received to provide providers with LGBTQ affirming training. So please take us up on that. We're really passionate about bridging these gaps and helping people have better mental health care throughout our state, especially in cancer care as well.
Wow, that was beautiful, Max. Really powerful. Thank you. And now we're going to put some pressure on our final panelists. Ryan, for mental health. Wrap it up, Ryan.
Wow, that is some pressure. Hi, everybody. So for most folks who are struggling with a cancer diagnosis, anxiety and depression perhaps intuitively are going to be the two feelings that they feel the most. But when you drill down on those, an important support system, begins to emerge right away. And Gabe spoke to this, and others have spoken to this. But I want to speak specifically to you, the individuals in the audience who are perhaps best qualified, or perhaps even uniquely qualified to be those advocates that step in those moments for depression and anxiety with cancer. It can be incredibly lonely. It can be incredibly isolating. I lost my father to lung cancer, so there was the additional stigma of his behavior for being a cigarette smoker that accumulated to his feelings of anxiety and depression at the end of his life. And so for those of you who are providers and or allies and or work for nonprofits in this space, creating moments for folks to be able to talk candidly about their depression or their anxiety, they are already seeing themselves as a burden to their colleagues, to their loved ones. So you, in this space, I really call on you each individually to get deep with somebody about their depression and their anxiety journey, because I can promise you they're having it. If they have a cancer diagnosis, the odds are overwhelming that they are feeling either depression and or anxiety. And so getting real with them, asking open-ended questions, saying as little as you can, and asking open-ended questions to get the other person talking. And when it comes to a point where you feel that it's appropriate to respond, it is okay to say, wow, that sucks, or gosh, that is tough. And to just be there with that person, not offer solutions, not spool off resources, not, get into a habit that we all are guilty of when we confront someone who we want to help. And then I'm an Enneagram 2, so I want to extra help that person. but you just need to create the space for them to talk openly about their own depression, their own anxiety journey. And the other thing for folks who are experiencing the diagnosis for the first time, or who are kind of reeling from the diagnosis, third spaces. Shout out to Laura Jackson at Walmart. I don't know if there's any Walmart people here today. She was the first gal who I heard speak about it. There's been books and stuff written about it too, but locally she's kind of a voice on it. If you go to school or work and then you go home, those are your two spaces, right? Everybody tends to either go to home or be at home, be at school or work, and then what is your third space? And for cancer folks, I saw my dad withdraw, and it was really tough. It was one of the toughest things about his final months. Don't withdraw. Keep your people in. Keep your people going to the things that they enjoy. Figure out a way for them to still attend Rotary. Figure out a way for them to still go to church. Figure out a way for them to cheer on the softball team from the sidelines. Because if they pull themselves, or they allow themselves to be pulled from those third spaces, it can be really detrimental to their mental health. So show up for your people. Listen to them when they want to unload, or if you want to create the conditions for them to kind of unload a little bit about anxiety and depression, because they can't do it on their own, or they don't have enough natural opportunities to do it on their own, most likely, seeing themselves as a burden or seeing themselves as being punished for their cancer. Creating that space, and then also making sure that they continue to show up in ways that they did before their cancer diagnosis, for like I said, for their intramural sports, for their after work activities, for their weekly Bible studies. Make sure that they still stay plugged into those activities, please, because that's really important to their cancer journey. I yield back to Dr. Mona.
Well, I think we have a few minutes left here. I appreciate you sharing, Ryan, and carrying the heavy load at the end. And I guess that, we're hearing the importance of conversations and early identification. Do any of you have comments or questions for the panelists? Please feel free.
Do you want me to run the mic out? Oh, she's got it back there. Okay, very good.
This is your chance to put our experts on the spot.
Shout it. Jason Craney, lifelong Iowan. I'm a professor at Des Moines University. I study cancer mortality. I've studied suicide mortality, overdose mortality. But it was very disheartening when I saw the elevated rates and overemphasis of disparities, suicide mortality among cancer survivors. And I've seen a lot of encouraging work, some of you in the room, about survivorship programs. Mm-hmm. There's a gap for rural communities. I'm curious, you mentioned third spaces, Ryan. My wife is a peer support specialist, someone with a lived experience for NAMI, Johnson County. And I'm wondering if you've seen any opportunity to bridge survivorship programs, and peer support, mental health, third spaces, if you will. Thank you.
Yeah, thank you. Short answer is yes. Unfortunately, a lot of those are virtual. But we do have some ones that have had success. I checked out actually before we came to speak today some of the online resources. They can be quite powerful. You know, I think a lot of folks, especially folks who are millennial, Gen Z, you know, loosely speaking, 40 and under, way more comfortable with interfacing with their peers on an iPad or through Zoom or through even other teleconference mechanisms. They don't chat. I mean, they don't flinch. So they can still find community and camaraderie and a sense of belonging online. And I don't want to put words in Max's mouth, but as a fellow LGBTQ person, I know that there are a lot of resources online that have really expanded post-COVID as well.
Well, you're a quiet audience. I guess you have a lot of food. Oh, we have another person up front. I was going to say we have a lot of food for thought.
Thanks for this great panel. I'm a cancer clinician, and I'm curious what, from a patient's perspective, when you're thinking about mental health resources, especially both going through treatment, but then after treatment, what is the most useful thing in terms of if somebody assesses a need, whether it's somebody with pre-existing mental health issues or somebody who's just having trouble dealing with the diagnosis, what's the most useful thing to offer? What kind of service? What kind of timing? You know, if we're going to improve our clinical services, what do you want? What do you need? What's the best way to do it?
Good question. Thank you for asking it. I think, like Ryan said, one of the most useful thing is helping the person make connections, because that's what's going to help somebody feel good about who they are. It's going to help somebody find somebody with a common ground that they have a connection to. So I think when you're looking at, if you're going to try to rate as to what is the most successful or what is the most useful, it's helping people make those connections. Knowing other people that have gone through colorectal cancer, and even in my case, now I have a stoma. I didn't know what this was. I never seen it. I never dealt with it. So knowing other people that can give you advice, that can lend you a hand to understand the changes that your body has just gone through, to me, that was one of the most useful things post cancer, is knowing other people that can help me learn about what just happened to me. Because that was one of the biggest struggles, is that I didn't know what was happening. You know, it just came on so fast, because treatment was fast, surgery was fast. So just having people understand who you are and what's going on with your body now.
I'm going to add to that. Just please encourage individuals that it's okay to ask for help. If I think about what, I'm going to use the term cancer culture here in the U.S., we talk about warriors and we talk about survivors and we ring the bell when we do our last treatment, and that's all wonderful stuff. But if you're dealing with depression, anxiety, or some other form of mental illness, then there can be this inner conflict, and I'm supposed to be a warrior. How can I ask for help?
Mm-hmm. I just have a comment back to you also, is the integrative care model. And in that model, to combine mental health, substance abuse, and primary care services to really connect with the patients early on that might be having some emotional distress, and not being afraid to ask those questions about, are you suicidal? Do you fear, do you have death wishes, and those types of open dialogue to open the door with your patients are really important. So any final comments?
Yeah, just real quick, it made me think, so anybody in here who has dabbled in mental health, including the panel on stage, WRAP, a Wellness Recovery Action Plan, WRAP, anybody hear of WRAP? That's kind of what I figured. Not very many of you. Look it up. WRAP. That's a good thing. I presume not many of you had heard of it. So getting folks to journal come up with a purpose, come up with a routine, come up with something that will get them thinking about what is on the other side of cancer. I think purpose, I know that we all kind of instinctively know that, but when it comes to mental health in particular, helping someone who's dealing with cancer find a sense of purpose is huge. So Google Wellness Recovery Action Plan, if you would, if you're in the space. I mean, if you're a practitioner or somebody who works with folks living with cancer, getting them to think about what is on the other side is vital for their mental health.
Well, and I know as we're wrapping up, one thing that I'm sure everyone in this room is thinking about is like when I talked earlier about the fact that like a lot of LGBTQ folks experience things like houselessness, and they're more worried about trying to access shelter and food than they are like going in for a cancer screening, much less like having insurance to get a cancer screening. I do think it's really important to talk about the things that keep people from accessing the care. Most United States Americans, like many United States Americans, like cannot afford an emergency that would cost them over like $500. We don't have our basic needs being met. We don't have universal basic income or free insurance. We are like criminalizing homelessness. I think that these are all things that we have to talk about when we talk about cancer care and mental health, because when I think about why someone would experience mental health disparities, especially if they get a cancer diagnosis, I think financial insecurity comes with that. And I think that that's really systemic and intentional. And so that, of course, hits LGBTQ people very hard, but it hits every marginalized group very hard. And so I hope that's something as well that's in the mix, because it's really hard to access cancer care and it's really hard to access mental health care, especially in Iowa. So I wanted to make sure to just touch on that too, because it's, as you all know, very systemic. So.
Well, we want to thank the Cancer Consortium for allowing us this time, and it shows the priority and the importance that they're placing on mental well-being in the cancer care journey. We also want to thank our panelists for their time and their talent. So please, let's give a round of applause.